Okay. And just go into a little bit more in depth about cephalosporins. Your first generation cephalosporins, going from first generation to fifth generation, you're going to have increased spectrum of coverage. You're also going to have increased resistance to beta lactamases. I guess just to kind of go into beta lactamases, your beta lactam antibiotics. Basically, there's a beta lactam ring that is present in your beta lactam antibiotics. That ring is actually going to, ir- irreversibly bind to uh, to your penicillin binding proteins, PBPs. Um, those are essential enzymes that are involved in the final step of peptidoglycan synthesis. Peptidoglycan is basically the working unit of the cell wall. That's what actually maintains the integrity of the cell wall of the bacteria. So basically, that beta lactam ring acts as a substrate for the PBPs. So once it binds to the PBPs, that prevents the PBP from finalizing that step in the peptidoglycans. Peptidoglycan synthesis. So instead of a strong unit of that cell wall, you now have a weak unit. Weak unit of the cell wall. You now have hypertonic outside. Naturally, it's going to go from area of solutes, going to go from area of high concentration, low concentration. Kind of like having just having something in salt water. All the salt water is going to go inside and it's going to blow the bacteria up. Hydrolysis. All right. As I ramble, at any rate, your generations are going to be less susceptible to those beta lactamases. Your beta lactamases are actually produced by the various bacteria. It's going to attack the beta lactam ring. It's going to hydrolyze it, break it down, rendering it inactive, therefore preventing it from interfering with the cell wall synthesis. Okay. If you go into first generation, just as far as uses, you have surgical prophylaxis, cefalozin, skin and soft tissue. That's going to be, you'll see a lot of your Keflex, your cephalexin. Many times you'll see that 4 times a day, 500 milligram, maybe 750 milligram. Also, UTIs, you also see cephalexin. When you start getting into some of the heavier hitters, you might not see the cephalexin used as much. Next, you have also your second generation, a little bit broader spectrum, a little bit more resistance to beta lactamases. You'll have, and you may not go into gram negative and gram positive, but you'll have your Enterobacter, Neisseria, H. influenzae. Still does some gram positive, but is weaker than the first generation. You also have, AMA. We won't go into that. not necessary. Clinical uses, you'll have your respiratory tract infections, like your bronchitis, your otitis media, your sinusitis. You'll see on the retail side a little bit more cefuroxime than you will the cefaclor. Also UTIs and anaerobic infections. So that'd be more of like your intra-abdominal infections. You'll see some of that, the cefoxitin or the cefotetan. Okay. Third generations, that's going to be your ceftriaxone, which is your Rocephin, ceftazidime, and cefotaxime. All right, so you are going to have a stronger gram negative coverage, so that's your Enterobacter, Serratia, Neisseria. Less gram negative, that's going to be than the first and second. Like your ceftriaxone, cefotaxime, they're still strong. Ceftazidime does cover Pseudomonas aeruginosa, originosa. So you're going to use, you see the ceftriaxone, cefotaxime, meningitis. All right. It penetrates into the CSF pretty well. Your gonorrhea, you'll see a lot of Rocephin, a lot of shots in the hip with ceftriaxone. That if you have some of your more serious hospital-acquired infections, that's when you'll start seeing the third generation. And ceftazidime, once again, Pseudomonas infections. That's going to be that specialty for your third generation. That sets it apart. Fourth generation cephalosporins, cefepime. Okay. So you're going to have broad gram negative, gram positive. So basically, nosocomial infections. So basically, you're looking at just pneumonia, sepsis, and febrile neutropenia. Also, Pseudomonas will be covered by your fourth generation. All right. Let's see. And anything resistant to your third generation, you'll step it up to that fourth generation. All right. Next will be fifth generation cephalosporins. That one's going to cover, that's your ceftaroline. So that's going to cover your MRSA. That's what sets it apart. All right, fifth generation MRSA. Also Pseudomonas. All right. So MRSA, and soft tissue infections, and also CAP. So MRSA and CAP, fifth generation. MRSA and CAP, community acquired pneumonia. That's going to be your fifth generation. All right. Let's see. And there's a little chart to kind of go into it. But it's not too tough. All right. So, also on the note of beta lactamases, it may kind of help remember the beta lactams. You have, because naturally, if you have a beta lactam antibiotic, it's going to use the beta lactam ring as a mechanism of action. Bacteria have the counter to that, and it's kind of like the fuzz buster to the radar. You have for your penicillins, you have your penicillinases. So that's going to be like your Staph aureus, cephalosporinases. You also have extended spectrum beta lactamases. Okay, so those are going to be penicillins and third generation cephalosporins and monobactams. E. coli and Klebsiella pneumoniae. Those produce the ESBLs. And also carbophenamases. So that's going to be specific to carbapenems. All right. Also, just as a side note, you will see certain drugs have a combination beta lactamase inhibitors. So basically, you have an ingredient that will go in and inactivate the beta lactamase. Um, a lot of that you'll see your aminopenicillins, like amoxicillin. It'll have clavulanic acid. So you have um, augmentin, basically. All right, so we'll go in and actually bind to the beta lactamase and inactivate it before it can actually bind to the beta lactam ring to inactivate the beta lactam ring. So let's see. Let's see. And also, just as a note, cephalosporins, carbapenems, they're more resistant to the beta lactamases. So you don't have a necessarily additional ingredient, but they're just more resistant. Other than that, yep, I think that's pretty much that. Also, just as a note, another mechanism other than the beta lactamases, some bacteria will also have modified PBPs. In other words, the actual binding site for the penicillin binding proteins, where the beta lactam ring is supposed to actually bind and inhibit that cell wall synthesis. Some bacteria have a modified site to make it more difficult for that beta lactam ring to actually bind. And the next would be some bacteria actually have efflux pumps. So basically, it will pump out the the beta lactam antibiotic, just flush it out. Okay. So that's pretty much that. And also, one of the side effects of the cephalosporins is C. diff, and that's pretty much just anytime you have a broad spectrum antibiotic, it's going to also take out some of the normal flora within the gut. So you now have your beneficial bacteria diminished, which gives rise to the bad bacteria, the C. diff, to be able to proliferate. So just a little note on that. All right, we continue on.